Welcome to the Deep Dive, your shortcut to getting smart fast. Today, we're tackling something almost universal, low back pain.
Yeah, it's incredibly common. And we're zeroing in on the latest clinical guidelines, specifically for non-specific low back pain, NSLBP.
And the numbers are just staggering, aren't they?
They really are. Sources put it at, 60% to maybe even 90% of people in Western countries getting this at some point? It's huge.
Almost everyone then. And NSLBP, that's the key term here. It means, what does it mean exactly?
It means you've got pain somewhere between your lowest ribs and your buttock folds. But crucially, doctors can't pinpoint a single specific physical cause, like a fracture or infection.
Okay. And that non-specific kind that accounts for, like, the vast majority.
About 95% of all acute low back pain cases fall into this NSLBP category. So that's our main focus.
95%. Wow. And the impact isn't just personal pain, right? There's a bigger picture.
Oh, absolutely. The societal impact, the economic cost, it's massive. And here's something really interesting for, policymakers, employers. The vast bulk of the cost, maybe 88%, isn't actually medical bills. It's indirect costs.
Indirect, you mean like people not being able to work?
Exactly. Absenteeism, lost productivity, that's where the real economic drain is.
Okay, hold on. 88%. So it's not the MRIs, not the pills. It's people being out of action.
Precisely. The system isn't going broke from the treatments themselves necessarily. It's the immobility, the time off work.
That completely changes the perspective. It means getting people active again isn't just about feeling better. It's an economic necessity.
You got it. Which brings us straight to our first kind of surprising point. We're calling it the diagnosis paradox.
Okay, I'm intrigued. Paradox.
The core advice now, based on guidelines, is often to stop looking so hard for a specific cause of the pain in these NSLBP cases.
Wait, stop looking. That sounds wrong. Don't we need to know what's broken?
That's the traditional thinking, yeah.
Yeah.
I used to assume it was, overloading a disc or a joint or a muscle, something specific. But the modern guidelines are saying, look, for that 95%, the non-specific cases finding the exact little thing that's irritated is usually unnecessary for treatment. Sometimes it even gets in the way.
But, okay, play devil's advocate. I have back pain. I go to the doctor. Maybe I have good insurance. Why not get an X-ray or an MRI? Just to be sure. What's the harm?
That's the million-dollar question, isn't it? And the surprising answer from the data is that routine imaging often carries a real risk of making things worse for the patient.
Worse.
How? It comes down to what those images show and what they don't mean. There's a fascinatingly high prevalence of abnormal findings, things like bulging discs, degenerative changes, even in people with absolutely no pain.
No pain at all. Give me some numbers on that.
The sources we looked at show ranges anywhere from, say, 20% up to a staggering 76% of completely asymptomatic people.
76%.
Yeah, people walking around feeling perfectly fine who, if you scan them, would show things like disc herniation.
So I could be feeling great, get an MRI for some unrelated reason, and find out I technically have a bulging disc.
Absolutely. And the critical point is that finding often has zero clinical consequence for your actual well-being. But the risk...
The risk is seeing that picture.
Exactly. It can lead to what we call incorrect illness perception. Suddenly you think, my back is damaged. It ramps up anxiety.
Okay, I can see that.
And that anxiety fuels fear avoidance behavior. You start believing that movement itself is harmful, that you need to protect your damaged back.
So you stop moving.
You stop moving, which is the opposite of what helps. And this fear can drive unnecessary follow-up treatments, maybe even risky procedures, and it adds to those indirect costs we talked about, more time off work because you're scared to move.
So routine imaging can actually create a problem psychologically where maybe there wasn't a serious physical one.
That's the paradox. For the 95%, it can muddy the waters and increase fear.
Okay. So we avoid unnecessary anxiety for the vast majority, but we absolutely cannot afford to miss the serious stuff, the critical 5%. When do we need those images? What are the warning signs?
That's where clinicians rely heavily on spotting red flags. These are specific signs and symptoms that point towards a potentially serious underlying cause.
Like what? What are we talking about?
Things like cancer spreading to the spine, a spinal fracture, a severe infection, or a condition called cauda equina syndrome.
Cauda equina. That sounds serious. What is that quickly?
It's a major neurological emergency. Basically, severe compression of the nerve roots right at the bottom of the spinal cord.
And why is it an emergency?
Because it can lead to permanent problems like loss of bladder or bowel control or numbness in the saddle area. Needs immediate attention.
Got it. So what are the red flags that scream image now?
Key things include really acute, severe pain that doesn't change with position or movement, a history of cancer, unexplained fever or weight loss, new or worsening neurological problems in both legs, like weakness or numbness, or if someone's recently had a spinal procedure or injection.
Okay, those sound like definite stop and investigate moments, clear emergencies.
Of
But for everyone else, that huge 95% with nonspecific pain, the next big question is, why do some people get better fairly quickly while others get stuck? This leads us into thinking about the journey to chronic pain.
Right. And the natural course is actually pretty encouraging initially. About
Hmm.
50% to 75% of people feel significantly better within about 6 weeks.
That's good news, but
But
yeah.
there's a substantial group, maybe 25% to 50%, who develop chronic symptoms. That means the pain sticks around for 12 weeks or more.
3 months or longer.
Yeah. And even for those who recover initially, over half might have a relapse within a year. It can be in this revolving door.
So just waiting it out isn't always enough. And the guidelines have changed how we think about this, haven't they? It's not just about how long you've had the pain.
Exactly. The focus has really shifted. It's less about just labeling it acute, subacute, or chronic based on time, and more about identifying factors early on that predict who is likely to get stuck in that chronic cycle.
Prognostic factors. What predicts a poor outcome?
And this is fascinating. The strongest predictors often aren't physical findings on an exam or scan. They're what we now call yellow flags.
Yellow flags, meaning caution signs.
Kind of. They're psychosocial risk factors, things related to your thoughts, feelings, beliefs, and social situation.
Okay, tell me more. What kind of yellow flags are we looking for?
Well, things like high levels of anger or anxiety about the pain, especially that fear of the pain and fear of movement, that fear avoidance behavior we mentioned.
So being really scared of making it worse.
Yes. Also, certain beliefs are major flags, like being convinced there must be a serious undiscovered physical problem.
The person who keeps saying they just haven't found it yet.
Right, or feelings of helplessness, like there's nothing they can do,
Yeah.
or constantly seeking more tests, more specialists, because they don't trust the initial assessment.
That makes sense. What about outside factors? Work, social life?
Definitely. Things like being off work for a while already, low job satisfaction, or high stress at work, maybe monotonous tasks, feeling like you have no control. Those are significant yellow flags, too.
Wow. So it's a complex mix of internal feelings and external pressures. But you highlighted one finding in the sources that, honestly, it stopped me in my tracks. What's the single strongest predictor?
It's pretty striking. It's simply the estimation by the patient, or sometimes their doctor or therapist, that the back pain is likely to persist.
Just the belief that it won't get better?
Yeah, the expectation itself. The source material puts an odds ratio on it of 10.4.
10.4. What does that mean in simple terms?
It means your own belief about whether you're going to recover is over 10 times more powerful as a predictor of becoming chronic than almost any physical factor we can measure.
That's incredible. So if you think you're going to be stuck with this pain,
You are significantly more likely to be right. Your mindset is profoundly influential.
mind blown. Okay. Your mind is literally, statistically more powerful than your physical condition in predicting the outcome here,
It really highlights the power of perception and expectation.
which logically demands a completely different approach to management, right? Not passive waiting, but something active. This brings us to what the guidelines call the activating management strategy.
Yes, this is really the heart of the modern approach. The absolute core philosophy is promoting movement. It's
Yeah.
about encouraging people to continue or resume their normal daily activities, including work, as much as possible,
Even with the pain.
irrespective of the pain, within reasonable limits, obviously. The goal is to break that cycle of fear and inactivity before it leads to chronic problems.
So this is where we finally officially tell people not to just lie down and wait.
Absolutely. Let's put the old advice of bed rest firmly in the past. It's explicitly advised against.
Why? What does the evidence show?
Studies consistently show bed rest isn't helpful for NSLBP. In fact, it can be detrimental. It can lead to longer sick leave.
Longer.
Yeah, one study found patients advised bed rest took about 3.4 days longer to get back to work. Plus, you risk muscle weakening, stiffness.
Yeah.
Just makes things worse in the long run.
So if the pain is really bad, what then? Just push through.
Not necessarily push through agony, but limit rest drastically. If you absolutely need to lie down because the pain is severe, maybe just for a few hours at a time and only for a very few days maximum, the default should be staying as active as possible.
Okay, so activity is king. And this philosophy is put into practice with a structured plan, right? A kind of step-by-step approach.
That's right. It's designed as an intensification plan. You start with the basics, and if function isn't improving after, say, 3 weeks or so, you move up a step, always keeping an eye on the person's motivation and those yellow flags we discussed.
Makes sense. So step one.
Step one is foundational, information and advice.
Yeah.
Just educating the patient,
Well,
explaining that NSLBP is usually benign, that activity is good, hurt doesn't necessarily equal harm, setting the right expectations.
okay. Manage the fear from the start. Step two.
Step two is activity buildup, and this is where a really key technique comes in, the time contingent approach.
Time contingent. Break that down for us. What does that mean in practice?
It means you increase your activity based on a preset schedule, not based on how much pain you feel that day.
So instead of saying, I'll walk until it hurts too much.
You say, okay, the plan is I will walk for 15 minutes 3 times today. And you stick to that schedule whether your pain feels like a 3 out of 10 or a 7 out of 10. You decouple activity from the fluctuating pain level.
Got it. Taking the pain's vote out of the decision to move.
Exactly. Now, if someone's fear of movement is really strong, that's where physical therapy can help support them, basically coaching them to stick to that time contingent schedule.
Okay. What if that scheduled activity increase just isn't working after, say, 6 weeks?
Then we consider step 3, exercise therapy. This is more formalized exercise, guided by a therapist perhaps.
And is there a specific type of exercise that's best, like Pilates or yoga or weight training?
That's another interesting point from the guidelines. The emphasis is still on an activating and time-contingent approach. But generally, no single specific type of exercise has been proven superior to others for NSLBP.
Really? So it doesn't matter what you do?
What matters most seems to be doing something consistently, sticking to a schedule, and gradually increasing it. Whether it's swimming, walking, yoga, specific back exercises, the adherence and the activation principle are key, not the label on the exercise class.
Okay, consistency over specific type. What about people who are already in the chronic phase? Pain for over 12 weeks.
That brings us to step 4, behavioral treatment. Here we're looking at things like cognitive behavioral therapy, CBT.
Therapy for back pain.
Yes, because as we saw with the yellow flags, thoughts and beliefs are powerful. CBT aims to help people identify and change those unhelpful thought patterns, manage the fear, develop better coping strategies for living with persistent pain.
Right, tackling the psychological component head on. And the final step, step 5.
Step 5 is multidisciplinary rehabilitation. This is reserved for the most complex, persistent cases. People with a really high symptom burden, maybe they haven't returned to work. Strong psychosocial factors are clearly playing a major role.
So a more intensive approach.
Yes, it involves a whole team. Maybe a rehab physician, a psychologist, physical and occupational therapists, all working together in a coordinated program.
That 5-step progression makes a lot of sense. It really mirrors that shift away from just diagnosing something passively towards actively empowering the patient.
Exactly. Self-management and active coping are central.
Okay, let's wrap up by looking at some specific treatments people often ask about or are offered and see what the evidence actually says, starting with medications.
Right. Let's talk painkillers. Your common over-the-counter stuff like paracetamol, acetaminophen, and NSAIDs like ibuprofen or naproxen.
Yeah, the first things people reach for.
The clinical guidelines consistently rate their efficacy for both pain relief and improving function in NSLBP as well. Probably limited.
Limited, but they're prescribed all the time.
They are. And it's worth noting that NSAIDs generally don't seem to be much more effective than paracetamol for back pain, but they definitely carry higher risks.
Risks like?
Stomach problems, ulcers, bleeding, and also cardiovascular risks, especially with longer-term use or higher doses.
So maybe not the harmless pills we think they are. Is there a safer way to use NSAIDs?
One potential alternative is using NSAID gels or creams applied directly to the skin over the painful area.
Topical NSAIDs. Do they work?
They can provide some localized relief, and the advantage is much less of the drug gets absorbed into your system, so you have significantly fewer of those systemic side effects. Might be worth considering.
Okay. What about stronger stuff? Prescription painkillers, opioids?
Opioids. The guidelines are very cautious here. They're generally only advised for severe acute pain, like right after an injury, and only if weaker painkillers haven't worked.
And even then?
Even then, it should be for the shortest possible duration, ideally, a maximum of maybe 5 days. The risks of addiction, tolerance, and actually worse long-term pain outcomes are just too high with opioids for NSLBP.
So a very limited short-term role at best. What about other types of medications sometimes used for pain, like antidepressants or anti-seizure drugs?
Things like certain antidepressants, anti-epileptics, even benzodiazepines or muscle relaxants, generally, they are not recommended for routine NSLBP,
Why not?
largely due to a lack of convincing evidence that they actually help significantly with this type of back pain, combined with often unfavorable side effect profiles. The risks often outweigh any potential unproven benefits.
Okay, so the medication picture is underwhelming, I guess. Limited benefits, real risks.
That's a fair summary for NSLBP, yes.
What about hands-on treatments, chiropractic adjustments, manipulations?
Manipulations. The guidelines generally don't recommend them as a standalone treatment, a monotherapy. The evidence for clear clinical benefit is pretty uncertain.
Uncertain benefit. Any downsides?
There's a notable risk of minor side effects. Studies report anywhere from 30% to over 60% of people experience things like temporary soreness or stiffness after manipulation. Nothing usually serious, but common.
Okay. How about injections? People hear about epidurals, facet joint injections.
Yeah, or even procedures like radiofrequency ablation, trying to burn the nerves. For chronic NSLBP, the evidence supporting these kinds of invasive treatments is generally rated as low to very low quality.
Low quality evidence, meaning we just don't know if they work.
Pretty much. Their effectiveness is unclear or highly uncertain based on the current research. They rarely seem to provide a lasting solution for the non-specific type of pain.
So lots of procedures being done with shaky evidence behind them.
That seems to be the case for many of them in the context of chronic NSLBP.
Which brings us to the ultimate intervention. Surgery. Someone's had pain for years, they're desperate. What about lumbar fusion or getting an artificial disc?
For chronic nonspecific low back pain, the guidelines are quite clear. Surgical interventions like fusion or disc replacement are explicitly not recommended.
Not recommended at all.
Not for NSLBP. The consistent finding from research is that these operative treatments show no clinically relevant benefit over well-managed, active, conservative care.
Wait, hang on. No benefit compared to the stuff we talked about: exercise, CBT, staying active.
Correct. No significant long-term advantage in function or pain relief compared to a structured, non-surgical approach. And surgery comes with very real, substantial risks.
How substantial?
The data can be quite sobering. One study mentioned in our sources reported a 34% complication rate associated with disc prosthesis surgery.
34%, 1 in 3 people having a complication.
That was the finding in that particular study, yes.
For a procedure that, on average, provides no better outcome than sticking to an exercise plan and managing your mindset, that's huge.
It really underscores the message. The risks of invasive procedures are significant, while the benefits over active self-management are often minimal to non-existent for chronic NSLBP.
Wow. The clinical takeaway seems incredibly clear then.
It really is. The effective path is conservative, it's active, it's patient-driven. It's about building resilience both physically and mentally.
Okay, let's try to summarize the key takeaways from this deep dive. Nonspecific low back pain is incredibly common, yes, but usually benign. It's not typically a sign of serious damage.
Right, and the road to recovery is paved with activity, not rest. Movement is medicine here.
You've got to challenge that fear of movement, the fear avoidance, and focus on self-management, taking control through activity and mindset rather than chasing a quick fix, whether that's a scan or a specific passive treatment.
Exactly. Think of it less like a broken part that needs fixing, and more like a sensitive system that needs retraining and desensitization through gradual, confident movement.
Which brings us to our final provocative thought for you, the listener. We heard that staggering statistic. Your own expectation of recovery is the single biggest predictor of whether your pain becomes chronic, with an odds ratio over 10.
Yeah, that belief factor is incredibly powerful.
So here's the question to ponder. Given that, how might shifting your mindset, actively deciding to focus on managing your function and behavior, rather than waiting for a cure or eliminating all pain, actually be the most potent treatment available to you?
Maybe stop waiting for the pain to vanish before you start living fully again. Perhaps starting to live fully is actually the way to help the pain recede.
Food for thought. Thanks for diving deep with us today. We'll catch you next time.